aspect of the systems we're talking about. That's not the purpose here. Our purpose here is simply to remind you, apprise you of the relevant terminology. We talked in the physiology about the adrenergic and the cholinergic neurotransmitter systems. Today we're going to quickly look at a brief overview of the autonomic nervous system, which includes both of those physiological neurotransmission systems of neurotransmission. So you need to know the scaffolding, you need to know the infrastructure upon which those systems operate. I think we left off talking about the structure and the organization of the cardiovascular system. We talked about the relationship between arteries and veins. We talked about the fact that the venous system in general is a fairly low pressure system, and consequently requires supplementary or additional mechanisms to ensure that blood is returned to the heart, because there simply is insufficient hydrostatic pressure in some cases to return the blood efficiently to the heart. So we indicated that the veins of the limbs in particular have these unidirectional valves, these check valves, that allow the blood to flow in only one direction. And so as the deep vein is squeezed, is compressed by surrounding skeletal muscle, that's going to push the blood in both directions. It can't go in one direction. It can only go, in this case, toward the top of the illustration. So for that reason, the musculovenous pump contributes to the return of blood back to the pressure generator, which is the heart. Varicose veins are a species of superficial vein. Remember, we talked about the distinction between deep and superficial veins. They can sometimes have a pathological or acquire a pathological appearance, such as you see here. They become more tortuous in this case, referring to many more bends and inflections. And as that happens, circulation is impeded. The entire function, physiological function of the vein is impeded, aside from the cosmetic aspects, which are sometimes addressed, which can sometimes be addressed surgically. You live in a time where they're bioengineering not only little kidneys, they have artificial kidneys now. They have certain lymphatic sinusoids that are artificially contrived. There are a couple of reports of artificial trachea being implanted, and there's artificial blood that's becoming more useful by the year. And this was just a report recently of a mechanism whereby human cells could be placed again on one of these sort of inert plastic scaffolds, and in that fashion result in the generation of a somewhat functional blood vessel. Again, keep in mind the difference between the veins and the arteries. This will be easier for veins because you're dealing with a much lower pressure system.
Professor, regarding the varicose veins, is there any way that one can avoid getting them, or they're more genetically defined?
I think as I understand the literature, as with most of the conditions, you think about the majority of the conditions with which you as a PA will be addressing. Heart disease, diabetes, asthma, that sort of thing. There are both genetic and environmental components. And certainly with varicose veins, there's a fairly high genetic component. But as I peruse the literature, I think, as far as I can tell, behaviorally, in terms of what you can do to avoid it, activity, the life of activity seems to be preferable and less likely to result in varicose vein formation than a sedentary lifestyle. But beyond that, I'm not sure that there's any specific diet or supplement that has been formulated for that purpose. Which is not to say that you won't get that if you're a marathon runner, you won't get varicose veins. We'll have more to say about the lymphatic system as we proceed. Basically, this is a one-way system. This is a drainage system that circulates lymph throughout the body. It's important to realize that lymphatic drainage is always distal proximal. It's always from the peripheral regions to to the center of the body. By center, I mean that lymphatic fluid is always being drained in this direction, always back toward the heart, because eventually these vessels, these lymphatic vessels, will drain their product into the venous circulation. There are two primary lymphatic vessels in the body. When I say primary, two very large vessels. The thoracic duct, sort of a large medial duct, and then there's also the white lymphatic duct, which drains everything up in this region. Everything else that is returned to the venous circulation, the vena cava, basically re-enters through the thoracic duct. The lymphatic system serves a number of functions depending upon where it's located, but it is an important immunological vector in as much as it carries a variety of leukocytes that help the immune system perform its function. Structurally, we're more concerned with anatomy. Here, it consists of lymphatic vessels, capillaries, and then a variety of other structures that are generally described as lymph nodes, lymphatic nodules, and then there are also some explicit lymphatic tissues, such as, for example, the thymus. The spleen is a highly lymphatic tissue. But what you find in all of these tissues are dense aggregations of lymphocytes that have the sort of histological appearance that you see here, these sort of spheres of lymphocytes clustered together. And again, depending upon the size of these structures, they're generally called nodes, nodules, or organs. The lymphatic vessels themselves contain the lymph, and the lymph, you can see almost like a tapeworm here. This is a typical lymphatic vessel here, and you can see it has lots of check valves in it. Analogous to the check valves in the veins, this facilitates the movement of lymph in only one direction. Low pressure system, virtually no pressure in the system, so once again, this facilitates transport of the lymph back to the central region, back on both sides where it drains in the venous angle, what's called the venous angle on both sides, close to where the jugular and the vena cava, the subclavian, I should say, the jugular and the subclavian come together. A typical lymphatic structure, such as you see on the top right here, we make reference to incoming vessels, afferent lymphatic vessels that bring the fluid, bring the lymph to the lymph node. In that lymph node, you can see there'll be a high concentration of lymphocytes and sometimes scavenging cells that will process the lymph. And then over on the other side, you're going to see efferent lymphatic vessels that will then discharge the processed lymph. And that too may include a small concentration of lymphocytes. The lymphatic tissue, as I say, will come up in our discussion as we talk about ALT tissues, ALT tissues. So we'll talk about BALT, GALT, MALT, and the ALT is associated lymphatic tissue. Associated lymphatic tissue, such as GALT would be gut associated lymphatic tissue. BALT, bronchial or bronchial associated lymphatic tissue, and so on. So oftentimes this lymphatic tissue, these aggregations of lymphatic tissue are located alongside these tubules, these luminal systems that open to the exterior of the body. You have lots of lymphatic tissue surrounding the entire GI tract along its length, especially toward the bottom end there. But you also have up here. What type of GI tract lymphatic tissue do you have in your upper GI? My guess is some of you have had them sort of, the tonsils, adenoids, tonsils. And then, as we've indicated, there's lymphatic tissue that's present along the intestines and the colon. And that's the concentration and extent of that is also going to be dependent upon the number of immunological challenges you've had in the course of your life. It tends to increase, but you might Why do they tell you not to feed chicken bones to your dog? And probably you shouldn't eat the bones either. The risk of infection, the risk of tearing the wall of the GI tract, allowing some type of infected in there. But again, that's the function of this lymphatic tissue along the GI tract to address the possibility of such infections. I mentioned the two primary vessels. You can see the thoracic duct here highlighted in yellow. So its function is basically to drain lymph from virtually the entire body, except for the head, neck, and the right side over here, into the venous circulation. And then the right lymphatic duct drains the right side of the head, the neck, the thorax, and so on. So we'll look at those in more detail later. Here's a little animation.
The lymphatic system is a network
Crank
of
up the
vessels,
volume.
lymphatic tissues, and organs, and lymphatic fluid known as lymph. As a system, it responds to pathogens and foreign substances. Throughout the body, fluid similar to blood plasma seeps from the blood capillaries into the spaces between cells. Approximately 10% of this fluid enters blind-ended lymphatic capillaries and is known as lymph. Lymphatic capillaries are microscopic vessels that are found among most blood capillary networks. Lymphatic capillaries converge to form lymphatic collecting vessels that merge to form lymphatic trunks. Lymphatic trunks drain into the largest lymphatic vessels, the right lymphatic duct and thoracic duct. The right lymphatic duct receives lymph from the right upper limb, thorax, neck, and head. It empties into the right subclavian vein. The thoracic duct is larger than the right lymphatic duct and receives lymph from the remaining regions of the body. It empties into the left subclavian vein. Lymphatic tissues include nodules and organs. Lymphatic nodules are collections of lymphocytes that lack the connective tissue capsule. They contain B lymphocytes, T lymphocytes, and macrophages that attack pathogens. Clusters of lymphatic nodules are associated with the walls of the gastrointestinal, respiratory, urinary, and reproductive tracts. Tonsils are large groups of lymphatic nodules found in the walls of the nasal and oral cavities. Tonsils provide protection against bacteria and other harmful materials that may enter the nasal or oral cavities. Pharyngeal tonsils are located in the nasopharynx and when inflamed are known as adenoids. Palatine tonsils, commonly referred to as the tonsils, are located at the posterolateral aspect of the oral cavity. Lingual tonsils are found at the root of the tongue. Lymphatic organs, including lymph nodes, thymus, and spleen, consist of clusters of lymphatic cells that are surrounded by a connective tissue capsule. Lymph nodes are small, bean-shaped structures located along the course of lymphatic vessels. In selected regions of the body, lymph nodes are found in prominent clusters. These are particularly evident in the axilla or armpit, the inguinal region or groin, and in the cervical or neck region. The primary functions of the lymph node are the production of new lymphocytes, filtration of the lymph, and initiation of an immune response when necessary. A lymph node consists of an outer cortex, which contains lymphatic nodules, and an inner medulla that contains connective tissue cords lined by lymphatic cells. Lymph enters the node through afferent lymphatic vessels and courses through channels called lymphatic sinuses in both the cortex and medulla. After filtration, lymph leaves the opposite side of the node through efferent lymphatic vessels. The thymus is located in the thorax, anterior and superior to the heart. It is the site of formation and maturation of T lymphocytes and is most active during childhood. Starting in adolescence, the thymus is progressively replaced by fat and connective tissue and eventually becomes non-functional. The spleen is the body's largest lymphatic organ. It lies in the abdominal cavity, just inferior to the diaphragm on the left side of the body. The spleen filters the blood, removing old or defective blood cells, foreign materials, and pathogens. It also helps to regulate circulating blood volume. Like lymph nodes, the spleen is involved in the production of new lymphocytes and in initiating immune responses.
There was the initial discussion about the tonsils being protected. I'm not sure there's a lot of evidence that the tonsils are actually protected. It seems we go in phases with respect to how rapidly they are removed when there are problems. How many of you still have your tonsils? Yeah, and probably for your, I don't know, I won't say your parents necessarily, but there was a time when I would say half the American population, with the treatment available to them, had them removed. We seem to be in a more conservative phase now. But in any case, it's arguable that their function is not entirely protective in the short term, but perhaps protective in the long term through antigen presentation. You have stuff in your tonsils that has been there for a month or more. There are a couple of pathological conditions you should be familiar with. So lymphedema just implies usually a swelling of a distal limb, often through accumulation of ECF or ISF more specifically. It can be lymph that is accreting, or it can be some other component. Lymphadenitis refers to inflammation of the lymph nodes. Lymphangitis is inflammation of the lymphatic vessels, and they can be of different severity. But lymphedema can be caused by any number of pathologies. Probably in your line of work, you will see this following, for example, blockage of lymph nodes and lymphatic vessels in cancers, for example. All right, let's move on to a quick discussion of the nervous system. Bear in mind, our only purpose is just to acquaint you with the general concepts and terminology, and fortunately, we'll talk about a lot of these in the next few physiology classes, so there'll be a lot of overlap here. Anatomically, you need to know the distinction between the CNS and the PNS. The CNS is basically the brain and the spinal cord. Brain and the spinal cord. The peripheral nervous system is everything else, all the other neural components distal to the brain and cord. The term somatic can give us fits. Literally, somatic just means other related to the body. But the term is used in very general terms to refer to the efferent nervous system. And by the efferent nervous system, we talked about the motor system. So virtually the entire voluntary or motor system is somatic. However, we also differentiate the afferent components of the nervous system. You know, for example, you have special senses, and you also have what are called somatic senses. And the somatic senses are those, for the most part, that are associated with the skin. Tactile sensation, vibration, deformation, pain, temperature, and that sort of thing. But proprioception would also be a somatic sense. So there's a little bit of overlap there. Just want to alert you to the inherent ambiguities of this term. And we haven't even talked about the autonomic nervous system and the extent to which it is somatic. We need to say something about that a little later.
So is there a distinction between somatic and peripheral nervous system?
Not really, because if it is true, as we've suggested, that the term somatic can be applied to both the efferent and the afferent, the motor would only. Usually, when we talk about the motor, we can say that is almost entirely somatic. There's only a few exceptions, which are going to give you fits later. But afferent's a little different. The somatic afferent, or the somatosensory system, generally refers to integumentary sensations and proprioception and so on. two general classes of neural cell, the neurons and the glial cells. The neurons are we already talked a little bit about these. These are the active conducting cells of the nervous system, and then the types of cells that support them. And by the way, there are many more of these than there are neurons. Are the glial cells, and we've already encountered at least one type of glial cell. What's the myelinating cell of the peripheral nervous system? The Schwann cell. So the Schwann cell would be classified as a type of glial cell. Schwann cell is only present in the periphery. We have another type of glial cell we'll talk about in the central nervous system. But there are other types of glial cells too, and they perform a number of functions. They contribute to the blood-brain barrier we'll talk about. They help to mediate the transfer of nutrients to and from neurons from the general circulation. They behave whenever there's some type of infection in the nervous system, so they play a variety of roles. We talked about the distinction between action potentials and synapses. Just be aware that synapses are present in both the CNS and the PNS. Synapses, we've indicated, are very dense in the central nervous system, and we need to talk a little bit more about the structure of the sensory and motor systems. But ultimately, when you talk about voluntary motor function, it's all going to come down to one synapse between a neuron and a muscle fiber. Another term for them. And so I don't think we need to go over the definition of the synapse here. I think you've talked a little bit about that. We can see a couple of examples of synapse here. So this yellow neuron that you see on the left would be the postsynaptic cell. You can see a branching presynaptic fiber coming down to synapse with the dendrites on the postsynaptic cell. So the axon terminals at the top, the postsynaptic cell at the bottom. There's the nucleus or soma of the postsynaptic cell, and then here's our myelinated axon myelinated by Schwann cells capable of saltatory conduction that we discussed in the physiology course. You know all about the nodes of Ranvier. You know that from an anatomical perspective. In an arrangement like this, the motor neuron only sends signals in one direction, sometimes called Bell's law. There are about 3 different Bell's laws. But one Bell's law points out that motor neurons are only unidirectional and send signals in this direction. You can see something of the organization of the Schwann cell here. We'll talk more about that later. But you can see that it sort of wraps around itself here with the nucleus at the periphery. Again, Schwann cell is also called a neurolemma site. Neurolemma site, because this forms the neurolemma, the boundary, the sheath of the axon. Now, this structure down here, I think it's in the notes somewhere. We need to talk about it a little bit in the both this course and the other course. I think there's a slide addressing this later. This is a more peculiar thing. This is called a REMAC bundle. REMAC bundle. REMAC bundle, named after the person who discovered it. And I just see the illustration here. This thing is basically, you notice some cases on these high tension lines, they'll put spacers between the high tension lines to keep them from crossing and touching one another. That's what this cell does. A REMAC bundle is just a spacer. In fact, curiously enough, it's termed a non-myelinating Schwann cell. Non-myelinating Schwann cell, because it does not contribute to saltatory conduction. The best analogy I can give you is it's acting like a spacer to make sure that these axons don't interfere with one another. So the REMAC bundle does not contribute to saltatory conduction. And it's usually only present for very small axons, keeping them in the proper location. But it is a Schwann cell. So we're looking here at the organization of the central nervous system, we said, consisting of the brain and the spinal cord, both of which are encased in bone and protected in large part by bone. The CNS is important for everything from voluntary motor function to integration of the sensorium, all the senses that are supplying your awareness of the world around you, and of course contributes to the peculiar capability of humans called cognition, consciousness, identity. I don't know to what extent wasps and flatworms are capable of those things. Maybe they are. You know that we organize, or the spinal cord is organized into 4 general regions: the cervical, thoracic, lumbar, and sacral. We'll talk a little bit more about the anatomy of that. And what you should know, even at this point, is that in general, these spinal nerves that you see emanating or arising from the cord are associated with comparable levels of the spinal column. The only problem being that the spinal cord is much shorter than the spinal column. So in order for these spinal nerves, let's say in order for a lumbar spinal nerve to leave at the lumbar region of the column, it has to go down before it can go out. So that's why you see all of these nerves sort of pointing down. There are 8 pairs of cervical nerves, 12 pairs of thoracic nerves, 5 pairs of lumbar nerves, and depending upon how you count, 5 or 6 pairs of sacral or sacrococcygeal nerves. And you can sort of see the anatomical distribution on the right there, and we'll talk about the termination of the cord a little later. I think we defined a CNS nucleus earlier. Can anybody tell me the definition of the CNS nucleus? Nucleus is a cluster or an aggregation of neurons of similar function. So the term nucleus applies to the CNS. The equivalent term, or the corollary term that we use to describe a cluster of neurons in the PNS, remember what that is? Plexus is pretty good. Plexus is a little bit different, but I wouldn't call you wrong on a test. Usually called a ganglion, ganglion. But there are exceptions to both these, unfortunately, and we haven't been very strict over the decades in how we apply these terms. So know the difference between a nucleus and a ganglion. A tract is generally a peripheral aggregation of nerve fibers, such as axons, that are clustered together. But a tract is generally present in the cord. When we talk about tracts, we're talking about fiber bundles, bundles of axons that are present in the cord. A similar sort of structure in the PNS would be called a nerve. The nerves can vary in different sizes. Be sure you understand the distinction between gray matter and white matter. Gray matter consists primarily of neurons and neuronal processes, whereas white matter consists primarily of axons. It's in the cord, also tracts. In your cord, is the gray matter on the outside or the inside? Inside. In your brain, is the gray matter on the inside or the outside? Outside. So it's flipped. Make sure you know the difference between the two there. We'll talk a little bit about the meninges. The meninges is a protective fossil membrane system that lines both the brain and the cord. We'll have a lot to say about this in both courses, but for now, just understand that there are 3 components: the dura, the arachnoid, and the pia. The dura is outermost, the pia is innermost. The dura is much more robust, it's much thicker, much more tightly apposed to the skull. The pia is very, very delicate, and well, I don't know, I can't really think of an analogy. It's just very, very diaphanous, very, very delicate, and is so delicate that it actually, when blood vessels enter the neuropile, the parenchyma of the brain, the pia mater follows them in. And it just follows the entire length of the blood vessel into the brain, sort of acting as a delicate barrier between the blood vessel and the neuropile. So in the illustration over here on the right, the thing that's shaped like a butterfly there, that's the gray matter. The white matter would be out here. And then immediately surrounding that pink tissue then would be the pia and the arachnoid. You can sort of see, it's hard to see this illustration. And outermost out here would be the dura mater. they don't let us do this in class anymore, but here you can see that we've actually opened up the spinal cord. So we're looking at the spinal cord, and this white encasement here would be the dura mater. And so they've incised the dura mater, and you see the more translucent arachnoid inside that. If we cut that, we'd actually see the sort of brownish cord inside that. This is more relevant for the physiology, but I just want you to be aware of, again, the general organizational terminology. So we're looking at the spinal cord here, and we indicated that the butterfly is the gray matter. And so you'll notice that the gray matter includes, at each level in the cord, a dorsal horn pointing toward the back, and a ventral horn pointing anteriorly. And we could say, with a few exceptions, that the dorsal horn is primarily sensory. It's primarily afferent and receives the signals from afferent neurons. The ventral horn is predominantly motor. And I would like to tell you that same degree of specialization continues into the white matter, but that would be a falsification. What is true is that this region between the dorsal horns, this region right in here, those are the dorsal columns, and they are entirely sensory. So those are sensory tracts. Unfortunately, the rest of this is all over the place, so we'll fight that battle later. But I do want you to know that you should be able to identify the dorsal horn, the ventral horn at any level in the cord. We'll deal with that problem, that specific problem later. But if I just show you a transection of the cord, like something like this, you should be able to identify the dorsal horn or the ventral horn. Or I might ask you which is the sensory horn, which is the motor horn, and you should be able to make a similar deduction.
Will you repeat what was in between the two columns?
Yeah, these are called the dorsal columns, and they have some specific names we'll talk about later, and we'll actually look at the brainstem a little later and find where these lie. But I guess what my point is, the only accurate generalization I can make about the white matter is that all of this is sensory. For the rest, it's not that easy. Sometimes in mechanical traumas, I don't know, rapid decelerations or similar traumatic injuries, you will encounter avulsion of spinal roots, avulsion of spinal roots. And literally what that means is there has been some mechanical trauma sufficient to tear the spinal nerve away from the cord. And that can have various manifestations, but that's what we mean by avulsion. And that generally is not correctable. Perhaps in some miraculous cases it might be possible to address that. Syphilis, tabes dorsalis, refers to syphilis. I'm just pointing out here, this is a disease that's largely afflicts the dorsal horns. It can take many, many years, even decades to evolve, but it primarily affects the sensory component of the CNS, especially the cord. And you get progressive deterioration of the sensory half over time. So the CNS is the brain and the spinal cord. The PNS is everything beyond that. So we're sort of looking at some of the components of the PNS in the illustration on the right. The peripheral nerve structures include all of these magnificent nerves we'll talk about later. Nerves consisting of a bundle of axons. We've already talked in the physiology about the extent to which axons that make up the nerve are either myelinated or unmyelinated. We said that larger axons tend to be myelinated, and that whether they're myelinated or not, the larger the axon, the more rapid the conduction. Therefore, in general, you have large nerves innervating the limbs, and as those nerves project to distal regions of the limb, they become progressively smaller. We've talked about the neurolemma. That's the Schwann cell in the peripheral nervous system that encases the axon if it's myelinated. And we also talked about endo, peri, and epinurium. Right? So in physiology, you should be able to define those terms. What was the epinurium? Yeah, it's the connective tissue that encapsulates an entire large nerve, such as the sciatic nerve or the femoral nerve. Here's that silly critter that we talked about earlier called the Remac bundle. The only thing I want you to appreciate about the Remac bundle is that it is, for the most part, a single complex Schwann cell acting not to myelinate the small axons, but simply to separate them so as to preserve and ensure the integrity of the neural signals passing along those small axons. So you can see here, look at this, one Schwann cell achieving more than 20 axons. Oh, here it is. We already talked about this, so you're an expert on the terminology used to describe the connective tissue that surrounds the nerves. We talked about the distinction between peripheral nerves and nuclei. But it's important to understand, we'll have a little discussion of cranial nerves later. The cranial nerves emanate from either the brain or in all cases the brain, but what's the word I'm looking for? The higher brain centers and the brain stem, predominantly the brain stem. And these innervate, with a few exceptions, structures within the head. The vagus nerve is certainly different. Arguably, the spinal accessory nerve is a little different. But otherwise, these cranial nerves, structurally similar to the other peripheral nerves, but they innervate structures within the head. You can see an example here on the top right. Facial nerve. We'll talk about this extensively in the other course, but for our purposes in the anatomy, make sure you understand the division of labor that we suggested earlier. So here we're looking at a transection of the spinal cord, and we have dorsal horns and ventral horns. What you should be able to or begin the process of doing now is learn how you can look at a cord like this, a transection, and immediately determine which is ventral and which is dorsal. Typically, these dorsal horns tend to be a little skinnier, but the most singular feature is that they usually extend all the way out to the periphery of the white matter. Whereas you can see the ventral horns would tend to be a little fatter and do not extend to the periphery of the white matter. And so, is the sensory half of the cord at the top or the bottom? Top, all right, so yeah. This would be the dorsal at the top there. And so make sure, just a few other points of anatomy, make sure you know that all the signals that are interacting with the dorsal horns are moving into it. These are afferent neurons. These are sensory or afferent neurons. Down here we have motor neurons, and the signals are going the opposite direction.
Is it possible to have damage to just one part of one horn, and not?
Yes, and that's very often the case. That can happen in a variety of central nervous diseases, or it can happen in some type of traumatic trauma. It can happen in autoimmune diseases and tumors. All sorts of things could have that effect.
So they might be able to get sensory information, but not be able to control it.
That's more likely to occur in the cord, but yes, it can certainly happen even in the brain. But yes, that's very, and one of your problems, and as we'll talk a little bit about that in here, we're just going over the basic science and basic anatomy in these two courses. But one of your problems in the clinical coursework is you're going to have to do neurological assessments of patients and ascertain whether or not, because for example, the information coming in through your right hand ends up in which side of the brain, the right or the left? Yeah, the other side, the contralateral side. And what we're going to find is, depending upon the pathway, it either ascends on the same side or on the opposite side. So that complicates your job of trying to ascertain where the lesion, where the problem is, if there is a problem, and how to address it. And so, yeah, we'll talk a little bit about that in here, because I said you'll address that in more detail in the clinical coursework. But for now, I also want you to pay attention to those circles. And by circles, I mean you see a red circle here, and you see a green circle here. So what is that red circle? That's the cell body of what type of neuron? A motor. What you'll notice then is the cell body of a motor neuron resides in the ventral horn. Similarly, as you look at that illustration, the cell body for the sensory neuron lies in the dorsal horn. Is that correct as you look at that illustration? No, that's not the case. So make sure you note that. The cell body for the sensory neurons resides in what's called the dorsal root ganglion. Dorsal root ganglion, a sensory ganglion. And we'll beat that to death in both of these courses, but make sure you see that distinction. So this motor neuron is going to receive some type of stimulus, we talked about that, and then send an action potential from the ventral root into the ventral rootlets. These little things right here are called ventral rootlets, into the ventral root there. And in this, where you can see we have another problem, anatomical problem nature affords us. The sensory root and the motor root come together to form the peripheral nerve. And that's called the spinal nerve that we saw in the pictures earlier. So the spinal nerve is motor or sensory?
Both.
Yeah, that's right, yes, both. So it's a mixed nerve. So that's going to complicate our anatomy. And it branches, that peripheral nerve or spinal nerve then branches, as we're going to find later, into a anterior and posterior branch. The word ramus just means branch. But most of us find that sensory nerve kind of perplexing, because notice this, that means that it's picking up a signal here, an action potential is being conveyed. It then says hello to the nucleus as it's zipping on by, except I'm going the wrong way. It's zipping on by the cell nucleus, that's fine. In my brain, it kind of does that sometimes. It turns around, goes there. But I just want you to make sure these are afferent signals coming this way, and they're going to move right by the nucleus. So the nucleus plays a rather bizarre role with respect to the functionality of this neuron, which is called a unipolar or pseudo-unipolar neuron. So before I confuse everybody, make sure we understand that the motor signals are going this way, and the sensory signals are going this way. Don't worry about this right now. We'll fight that battle in just a moment. But are there any questions then about ventral horns, dorsal horns, gray matter, white matter, rootlets, roots, not talking about piglets, rootlets, roots, spinal nerve, and the location of the cell body for the sensory neuron and the motor neuron? Yes?
What's the inner neuron doing?
Yes. What we're looking at in this illustration is something called a motor reflex. So since we won't have time to talk much about this elsewhere in the course, we can address it briefly now. So what's happening here? This person has their hand exposed to a flame. That's going to generate a sensation of heat, right? That is then carried back by this green fiber. This is an afferent neuron. Here's the pseudo-unipolar neuron cell that's going to go back. And then in the cord, it may or may not encounter one of these, I guess that's a purple cell, called an interneuron, right? What could happen is that sensory neuron could hook up directly with the motor neuron, and then what happens when the motor neuron is excited here? It's going to send a signal down, action potential down, and what's it going to do? It's It's going to cause reflex contraction away from the flame. That's called a motor reflex. Now, getting back to the question, the interneuron is simply helping to process that signal. And I guess I would ask you is how many synapses are there in this somatosensory reflex? All right, I hear 2, I hear 3. How many synapses are there? Do we have a convincing and determined
In the whole reflex.
in that reflex pathway?
4.
All right, that is a disynaptic reflex pathway because of the interneuron. A monosynaptic reflex pathway we wouldn't have the interneuron, but there'd only be one synapse. How many neurons are there in a monosynaptic reflex pathway? 2. There's always going to be one more neuron than synapses in a reflex pathway. So, trisynaptic reflex pathway, how many neurons would be involved? 4. How many interneurons would be involved? Interneurons, 2. Right? Everybody see the arithmetic there? So getting back to your question, if you were a cat, you would be able to, even a decorticate cat can walk. What do I mean by a decorticate cat? Cat without a brain, cat without a cortex. I remember in the old, back in the 50s, they used to call me a cat without a cortex. But a cat without a cortex can walk because the motor routines are located in the spinal cord. Not so much true for humans. But in any way, getting back to your question, those interneurons in some cases and the associated neurons with them can sometimes store complex motor pathways that enable us to do autonomic functions. Autonomy.
So the neuromuscular junction is not common steps.
In this case, this would be a somatosensory. As we're going to find out, this is probably a pre-nerve ending. There's no synapse.
Neuromuscular.
Here, no, that would not be a neural part of the neural pathway. In this reflex pathway, I've never seen that. You can send a letter to your congressman. All right, let's take a break and we'll pick up.